We are live on YouTube. So we'll start in a minute. Would you like to take the questions in the end, or would you like to take them in the middle? Are you muted? Just check your mic. I think your mic is muted.
Yeah. So, hi. So, I think we can take in middle. So, I have divided the class in maybe two parts vaguely, one with the classic ones and then with the examples. So, as and when if someone needs, you can interrupt and you can,
Okay.
I can take it.
Okay, fine. I'll take care of that. No issues. Most of the questions are on YouTube, so we transfer those questions here.
Yeah, sure.
Right. But are you ready?
Yeah.
So we'll start. Yeah, good evening, everybody. Welcome to this evening episode of Pursue. And this is Pursue 2J, which is lymph nodal pathology. And we are streaming live from PGI Chandigarh via Kolkata. A very interesting topic, RS-like and actual RS cells, differential diagnosis of Hodgkin lymphoma. And to speak on that, we have a very bright, a promising pathologist from PGI Chandigarh, Dr.Pulkit Rastogi. He's done MBBS, MD and DM PGI Chandigarh. He's presently an assistant professor in the Department of Histopathology at PGI Chandigarh. He's got multiple awards, distinctions and honors, and I would like to read them one by one because this is something which is mesmerizing. He's got distinction in 7 subjects, which is physiology, biochemistry, pharmacology, pathology, microbiology, forensic medicine and toxicology, and obstetrics and gynecology. He is an MBBS batch topper in first MBBS, second as well as in final MBBS. He was awarded 5 gold medals in MBBS. He was also awarded the Best Outgoing Postgraduate Award from the department with a silver medal with a batch topper for 2011 and 2014 in PGI Chandigarh. He was awarded the Best Paper Award in the poster category at the 19th APNA in 2014, won the state and zonal level rounds and was the first runner-up in the national level in the 3rd National Hematology Quiz for postgraduates. He did his DM in hematopathology and was awarded the ICMR Financial Assistance for DM thesis. He was given the Best Paper Award poster category at the first annual Lymphoma Update at TMC, Mumbai. Best Paper Award for the Thalassemia and Sickle Cell Disease Time for a New Optimism bilateral workshop in 2016. It's not just academics. He was also the president of the ARD PGI Chandigarh, which is the students' union there. So he's a man with so many colors, and today he'll be talking on such a very important topic, which is RS-like and actual RS cells. Before I ask him to start, let me request you to keep your mic muted, your camera off, and please don't share your screen. With this, let me request Dr. Pulkit, sir, please share your screen and let's start. Thank you so much.
Thank you, sir, for the kind introduction, and I would like to acknowledge, sir, for giving me this opportunity to talk into this forum. And so, yeah, here I'll start my talk.
Yeah.
So everything is visible, fine. Am I audible?
Perfectly fine. Yeah, you are perfectly audible. Everything is visible. Please start. Thank you.
Yeah. So the topic seems interesting at the beginning. So it deals with RS cells, the Reed-Steinberg cells, and the RS-like cells. So let me just open the laser pointer option. Yeah, just a minute. And just switch it to green. I like. Yeah. So the topic deals with Reed-Sternberg cells and what are the mimickers. So basically we are dealing today with the differential diagnosis of Hodgkin lymphoma. So just I have to highlight that it is Hodgkin, not Hodgkins. So it is the current terminology that we use. So I have certain disclosures at the initial point, and yeah, so these are written here, and here I'll start. Just a minute. Yeah, sorry for the interruption. So yeah, so here I'm going to show you certain pictures. So these are the different pictures which have somewhat similar morphology. You can see there are these 11 pictures. So all these pictures, you can appreciate that there are some large cells, some with having some round nucleus, some with lobated nucleus, some with binucleation, some with mononucleation, some with polylobations. And then they have a bystander background population. Somewhere there are sprinkling of eosinophils, but majority have a lymphocyte-rich background with scattered histiocytes and somewhat. So at initial point, one thing is it is we are dealing with a sort of Hodgkin's lymphoma, but yes, are we truly dealing with a Hodgkin lymphoma or not? That comes from the morphology of the surrounding milieu. We have to characterize each case with the morphology of the background cell population. We will characterize the large cells as well as the bystander background population with the help of immunohistochemistry, and we also need inputs from the clinical details, whatever is available to us, and then we formulate the final diagnosis to label what these cells actually are. And when we applied this strategy, only the 4 of these cases turned out to be true RS cells representing the classic Hodgkin lymphoma cases, whereas rest were with a different diagnosis. And to surprise, the first one case out turned to be anaplastic large cell lymphoma. This case turned out to be EBV positive mucocutaneous ulcer. The 5th case turned out to be EBV positive DLBCL. Then these are the angioimmunoblastic T cell lymphoma and peripheral T cell lymphoma (NOS). This case turned out to be T cell rich large B cell lymphoma, and finally this case had 2 pathologies together. One is mantle cell lymphoma and another is a Hodgkin lymphoma. So what exactly, how we characterize these cells to reach at the final diagnosis, I'll be discussing in another hour in my subsequent slides. So today we are dealing with what are the characteristics of actual Hodgkin Reed-Sternberg cells and what are their mimickers which can pose a diagnostic pitfall in these scenarios. So to start with a little history, so these are the 3 pioneers who initially described the cases of Hodgkin's lymphoma. He is Thomas Hodgkin, she is Dorothy Reed, and third one is the Carl Sternberg, and they described this disease well in the early 17th and the 18th century. And this was the landmark first paper by Dr. Hodgkins, where he described the 7 cases of autopsy where he found something different pathology, different from the tuberculosis or other inflammatory conditions, and there was enlargement of the lymph nodes in spleen in these cases, but without any significant inflammation. So he described pretty well the whatever the gross findings were there and what are the H&E findings in those cases available at that time. So this was the picture that he clicked during that time. This was the one of the original Hodgkin's case by the Thomas Hodgkins, where he classically described these binucleate cells with the prominent nucleoli, some with mononuclear forms, and this is the characteristic illustration by Dorothy Reed of the this is a hand drawing made by Dorothy Reed of the composition of cells in Hodgkin lymphoma cases, where she very nicely described these lobated cells with a background population consisting of eosinophils, lymphocytes, and so on. So these drawings are still present in the Gordon's Museum at London and preserved there. So initially in this part, I have at least 1/3 of the time I'll devote in describing the classic Hodgkin's lymphoma morphology based on H&E, and then I will approach how we decide that these are the true RS cells or these are the false or the mimickers of RS cells. So when you have a slide, H&E slide with the suspected hematolymphoid neoplasms, and you encounter such cells We characterize them as Reed-Sternberg cells is the initial thought. So these are the classic Reed-Sternberg cells which have a binucleated, which have a two nucleus. These are the size measures about 13 to 45 micron. They have abundant amphiphilic cytoplasm. Sometimes the nuclei can be more than two, and they have a very pale chromatin. You can see through this chromatin, the nucleus may be one or more, but it is very prominent and eosinophilic. What is just magenta color or dark pink color like nucleus? And when you have a such cell with a single nucleus, the mononuclear variant is termed as Hodgkin cells, not the RS cells. So HRS cells, Hodgkin Reed-Sternberg cells or Reed-Sternberg cells are same terminology, and Hodgkin cell is used when you have a single nucleus. So in such cases, we do encounter different morphologies, and these have been called as Reed-Sternberg cell variants. So these can be either lacunar cells, so characterized by a typical retraction artifact in the cytoplasm, where you have a clear cytoplasm around the nucleus. And it is typically seen in cases of nodular sclerosis variety of Hodgkin's lymphoma, though they can be encountered in other subtypes as well. The next variant of the Reed-Sternberg cell is a mummified cell, where you have this condensed deeply basophilic cytoplasm, giving it just a stone-like appearance. These are also the Reed-Sternberg cells based on morphology. And third variety is seen in nodular lymphocyte predominant Hodgkin's lymphoma, called as NLPHL, and these are called the LP cells, lymphocyte predominant cells. And they have an appearance typical of a popcorn-like thing, exploded kernel of a corn, and these have large centroblast-like cells with complex lobulations and folded nuclear membranes, and the nucleus is placed peripherally. It is somewhat basophilic compared to the eosinophilic nuclei, and also the size of the nuclei is somewhat smaller as those seen in your lacunar cells or other classic varieties of Hodgkin lymphoma. So these are the different morphologies on H&E that you can encounter in cases of Hodgkin lymphoma, be it classical or NLPHL type. So as I have already mentioned, so as per WHO 2017, it has retained the initial classification of 2008, and they are still into two major categories: the nodular lymphocyte predominant Hodgkin's lymphoma and the classical Hodgkin's lymphoma, which is further subdivided into four categories, the traditional, which are we learn during the MBBS curriculum as well. However, and no new entities have been added to this, thankfully, and no dropouts have been made. However, more literature has been added for the immunophenotype and the genetic pathways for the cases. Now, while approaching a case of these large polygonal cells and such polymorphic background, one should always give attention to the clinical history, whatever is available in the requisition form, or do not hesitate to call a clinician if nothing is mentioned in the form. Do look at the age, as a certain soft pointers can be made based on the age. Like classic Hodgkin's lymphoma typically has bimodal age presentation, the two peaks in young patients as well as in older patients, whereas NLPHL is usually seen in elderly patients. It is rarely seen in pediatric age group. So before making a diagnosis of NLPHL in a pediatric, think of another diagnosis. Secondly, B symptoms are rarely observed in NLPHL compared to your classic Hodgkin's lymphoma. The pattern of involvement can sometimes give a clue, as classic Hodgkin's lymphoma usually presents with neck nodes or the mediastinal nodes. This is the frequent history, patient present with a mediastinal mass or a SVC obstruction sort of thing. And the nodular sclerosis is usually a above diaphragm disease at the onset, though at the later stages it can spread to anywhere. Whereas mixed cellularity usually presents as small disseminated nodes, predominantly below the diaphragm region or organ involvement at the initial phases. These are certain soft pointers, whereas NLPHL is almost always involves the peripheral nodes, which are palpable nodes in the neck, submandibular region, axillary, or the inguinal region. Coming to the extranodal spread of the disease, the spleen can be involved usually at the advanced stages, and also in cases of mixed cellularity Hodgkin's lymphoma, the liver involvement is rare, and if it is involved, it is usually a concomitant splenic involvement can be seen. The bone marrow involvement is usually present at the advanced stages, and it is a very less frequent in case of Hodgkin's lymphoma. It ranges from 5 to 10% in the classic Hodgkin's lymphoma, apart from the lymphocyte depleted, where it is expected to be pretty commoner than the other varieties. In the lymphocyte depleted, it is 50 to 75%. Now coming to the histopathological approach for the classical cases, the RS, the true Sternberg cell cases, and with their IHC pattern, I'm going to describe in my further subsequent classes slides. So this was the again switch to the Thomas Hodgkin's cases. So this was one of the case. This was the seventh case of the Hodgkin's report, and this is the watercolor drawing made by the Robert Carlsware. In that paper, we very beautifully described the involvement of the neck nodes as well as the axillary nodes, and it was very large conglomerate masses of the lymph nodes. And this is the actual gross pathology depicted in one of the preserved specimen at the same museum. This was the case 2, where the abdominal nodes were preserved, and they were shown as conglomerate mass of lymph nodes with a homogeneous cut surface. So this is still available at the King's College London in the Gordon Museum. So coming to the histology, so at this, this is one of the section. Let's discuss what is this. So here you have a excised lymph node, intact lymph node was sent to us. It is somewhat thickened capsule, and you have some preserved follicle architecture, but majority you can see that the normal architecture is lost, and you have large areas of sclerosis, and as highlighted in this higher magnification, you have these nodule formation is there surrounded by white fibrous septae, and on high power you have those classic lacunar cells. So the working diagnosis on HNE is a nodular sclerosis, classic Hodgkin's lymphoma. So this is, I'll stop here, then after few slides I'll discuss the IHC of these cases. Another scenario is you can have a core biopsy, which is a common fashion these days to do quick core biopsies by the intervention radiologist, and it poses a challenge to pathologists sometimes while interpreting. But now we have to get used to these biopsies, because in certain scenarios this is the only possible way to get the diagnosis, because in cases of abdominal lymph nodes they usually perform the core biopsies. So this was one of the core biopsies submitted to us, where you have these pale fibrotic areas and some vague nodular appearance of the lymph node, and some blue areas can be appreciated. On high power, so this is the closer magnification, where you have a polymorphic population of hematolymphoid cells, and scattered large cells can be observed here and there, and this is the higher magnification to show those scattered large cells, some spindly cells, fibroblasts, macrophages, lymphocytes are there, and these are called as your, which I described as initially as your mummified cells. So in this case the working diagnosis was nodular sclerosis, classic Hodgkin's lymphoma. Sometimes you can have a variant morphologies within a nodular sclerosis Hodgkin's lymphoma. One is the syncytial variant, where you have large cohesive sheet of these atypical lobated cells, and these are CD20 positive. So this is a syncytial variant. Sometimes you can have areas of granulomatous response or areas of necrosis in the nodular sclerosis variety of Hodgkin's lymphoma, or in other varieties as well. So you can encounter these cases, and you should always look for the Hodgkin cell in such cases if there is a clinically strong suspicion of Hodgkin lymphoma. This is one of the case of a syncytial variant of Hodgkin's lymphoma, where you have these large nodules comprised predominantly of the this lobated cells, the Hodgkin cells, the lacunar cells, and these were pretty well highlighted on the CD30 immunostain, these large aggregate of CD30 positive cells. So in this the diagnosis was clear cut. It was a syncytial variant of Hodgkin's lymphoma based on the other typical IHC pattern. Then you have a mixed cellularity, which is characterized by paucity of fibrosis, but there is profound admixture of inflammatory cells admixed with these classic binucleate RS cells. And you can see that very pink cells are there. So these are the eosinophils. You have macrophages, fibroblasts, lymphocytes. So it was a classic example of mixed cellularity type of Hodgkin's lymphoma. The challenging subtype of a classic type, which I feel is the lymphocyte-rich classic Hodgkin's lymphoma. So it is rarely seen. It is a very rare diagnosis even in our setup, and usually the two patterns described with this subtype are the nodular pattern and the diffuse pattern. So here the characteristic finding is that the background cell population is comprised predominantly of small size lymphocytes, which are those of a typical mantle zone like thing. So at low power, the nodular pattern shows a weak nodular architecture, as you see in a follicular lymphoma or your NLPHL. So these are the differential diagnosis. But when you have a closer view, you can appreciate some residual regress germinal centers, and you have this expanded mantle zone in these cases. And when you will look for them, you can hunt certain these it polylobated cells, and these are characteristically described in cases of lymphocyte rich Hodgkin's lymphoma, and their location is characteristic, that is within the mantle zones of the germinal centers. Sometimes they can be seen within the internodular areas as well. And the nodules have the irregular borders compared to follicular lymphomas or the NLPHL. And very rarely you can have a diffuse pattern of growth where the background population is of T lymphocytes, and the scattered large cells are display the characteristics of classic Hodgkin's lymphoma. But it is a typically challenging diagnosis. The fourth variety is also rarely seen, typically associated with immunodeficiency, and this is the lymphocyte depleted, where you have marked paucity of the background cell population. There's a architecture is effaced, and you have scattered bizarre cells which are multilobated, very dark nuclear pleomorphic cells, and these are the described as pleomorphic variants of Hodgkin's cells, and this is typically seen in lymphocyte depleted Hodgkin's lymphoma. Here you have disordered fibrosis, and they have a characteristic background fibrillary matrix or amorphous pink staining material. The necrosis is common in these cases. So this is a classic morphology of a lymphocyte depleted variety of Hodgkin's lymphoma. The fourth, another subtype apart from the classic is an NLPHL, where you also have an effacement of the nodal architecture with formation of nodules. So these are the nodule formation. Here you can see that these large nodules are there, hardly any residual follicles, and these nodules are very closely packed, and at low power you can see some white spaces, typically called as the moth-eaten appearance of these nodules. And when you look at these closer view of these cases, you can encounter these popcorn-like cells with a basophilic nucleus, peripherally located nucleus, and at higher magnification you can further appreciate these popcorn cells. So the working diagnosis in these cases can be nodal lymphocyte predominant Hodgkin's lymphoma. So this was all about the H&E morphology and H&E interpretation. Now, when we apply the immunohistochemistry and how the story changes based on the interpretation, I'm going to discuss. So for the true RS cells, the panel of IHC comprises of level 1 IHC that we usually follow. So these are the 6 antibodies that we initially ask for a case of suspected Hodgkin's lymphoma. This is the CD45, a B marker CD3, CD20, CD15, CD30, and PAX5. If everything goes fine, corroborates with the diagnosis of Hodgkin's lymphoma, we stop at this level. However, if something goes different or a haywire, we order this level 2 IHC based on the pattern of these markers, and we further order other B markers like 79A, IRF4, MUM1, and these I'll discuss in my further slides and how to approach. And if this is also not satisfied, then we go for the level 3 IHC, which are the OCT2, BOB1, J chain, and PU1. So this is a typical classic immunohistochemistry of a classic Hodgkin's lymphoma case. This is a CD30 pattern which is showing membranous positivity with a Golgi zone accentuation, and it should be uniform, strong in all these RS cells to call it a classic Hodgkin's lymphoma. So remember, I'll stress uniform, strong in all those large cells. It should not be discontinuous, very haphazard, or just membranous or just Golgi zone. CD15 has a flexibility. You may see or may not see the Hodgkin cells to be stained with 15. It depends on the type of clone as well. But also, as compared, suppose 100 cells are positive for CD30, you can have just 70 cells which are positive for CD15, and that too in a discontinuous membrane-like fashion, though classically it is described as complete membranous with Golgi zone accentuation. Sometimes CD15 helps, sometimes it may not help. CD3 is characteristically negative in all cells. Sometimes it becomes difficult to interpret the CD3 immunohistochemistry, but one has to just go with the more and more practice to interpret the CD3 IHC, and here you can see that the two cells are sitting together and you have hardly any Dept staining in between these cells. This means that this is a negative in stain. And similarly for the CD45, this is a typical negative pattern. If it would have been positive, it would be complete brown here and there. So this is a CD45 pattern. CD20 immunostain is a pitfall, characteristically described as Hodgkin cells are CD20 negative, but Hodgkin cells can be CD20 positive as well. I'll discuss in my further slides how to interpret the CD20 in Hodgkin cases. And the PAX5 is a very nice stain, very good stain, helpful stain in making a diagnosis of Hodgkin lymphoma. So you have to compare it with the background B lymphocytes, which are strongly positive in all cases, and then you compare the intensity of this B lymphocytes with these Hodgkin cells as showing a typical weak nuclear positivity in Hodgkin. So this is a classic IHC pattern which one should encounter while giving a sign out of classic Hodgkin's lymphoma. So there are certain caveats in these 6 IHCs. So I'll discuss for the CD30. Yes, CD30 is always positive almost in 100% cases of Hodgkin's lymphoma. So this is a must positive stain to call it a Hodgkin's lymphoma. Then you have these cases. Another pitfall is an anaplastic large cell lymphoma. The third pitfall is a very dangerous pitfall is positivity in B and T immunoblast. Sometimes some plasma cells can be positive with CD30 and your embryonal carcinoma. So these are the caveats. CD15 is positive in 75 to 85% cases of classic Hodgkin's lymphoma, and as already told, only in a minority of neoplastic cell population, and it may be restricted to the Golgi zone. And the internal control for CD15, whether it is worked or not, should be a granulocyte like neutrophils or the eosinophils. For CD20, so this is an important one. CD20 can be seen in about 30 to 40% cases of classic Hodgkin's lymphoma, as the Hodgkin cells have been shown to be derived from B's lineage rather than any other lineage. So that's why they show a crippled CD20 positivity, which is described as weak and heterogeneous. That is, some cells will be positive, some will be negative, and the pattern of positivity, it will be discontinuous membranous positivity. And however, if the CD20 is strongly positive, that is homogeneously strongly positive, just like CD30, and then it makes suspicious whether the case is actually Hodgkin's or some other case. I'll describe in the further slides. Then you should order certain more B markers like 79A, and then you can think of any other alternative diagnosis. But inhomogeneous, heterogeneous expression CD20 can go with your diagnosis of Hodgkin's lymphoma, classic variety. CD45 is a difficult stain, so less useful in diagnostic factors, but yes, sometimes can be helpful if you can interpret it well. Other markers which have come up in the recent years are the J chain. So J chain is 100% negative in classic Hodgkin's lymphoma. We have procured this antibody last year, and it shows very well negativity in cases of classic Hodgkin's lymphoma, whereas it is positive in your NLPHL variety. That is pretty helpful. The MUM1 stain is strongly positive in your classic Hodgkin's lymphoma, whereas it is negative or weak positive in your NLPHL or other lymphomas or B cell lineage. OP2, BOV1 are transcription factors which are negative to weak in cases of classic Hodgkin's lymphoma. It is strong in cases of NLPHL. So these are the different panels. If you don't have a conclusive evidence, or if your PAX5 doesn't work well, then you go to these markers to reach a conclusive diagnosis. Finally, you can do the Eberish, the EBV encoded RNA in situ hybridization to identify the EBV association for the Hodgkin's lymphoma, or in certain cases, this can be helpful in making a differential diagnosis from other similar simulating conditions of Hodgkin's lymphoma, which I'll discuss in the subsequent slides. IHC for NLPHL is typically described as negative for 15 and 30, and they are positive for B cell marker CD20, 79A, 22. They show strong PAX5 expression compared to the classic one. CD45 is positive. They are positive for J chain, and they strongly express transcription factors OP2 and BOV1. So this is the example which I've shown on the HNE, and these the nodules can mostly positive for CD20, and though there are certain patterns, and you can have T cell rich nodules, but classically the nodules are CD20 positive, and the neoplastic cell population is CD20 positive here also. So the nodules are also positive, and the neoplastic cell population is also positive. So it becomes sometimes difficult to identify, but one has to closely inspect within the nodules as well as in the interfollicular region to look into these large atypical cells. The other immunostains which further consolidate the diagnosis, strong expression of the J chain, and you have rosetting of CD57 positive cells around these neoplastic LP cells. They also show rosetting for CD3, and the CD20 immunostain shows a very circumscribed nodular pattern of these nodules as compared to your lymphocyte. The differential diagnosis here is a nodular variant of lymphocyte-rich classic Hodgkin's lymphoma. So both have a B cell-rich nodules, and both have T cell rosetting around your large polylobated cells. So NLPHL as well as a nodular lymphocyte-rich classic Hodgkin's lymphoma have a similar sort of morphology on H&E. The thing which distinguishes is NLPHL will have such type of rosetting of PD57 positive cells, and these are also positive for PD1, whereas this lacks in cases of your classic Hodgkin's lymphoma, a lymphocyte-rich subtype. So this is a close mimicker, but yeah, one has to have a good section of immunostains to make a differential diagnosis. So now coming with the actual thing, so this is about the 1/3 of the class, and till here, any questions?
Yeah, there are quite a few questions. I have put them all on the chat box. I'll read it out for you if you want, or you can read it if you're comfortable reading it.
Yeah. So Dr. Pranav Kumar, role of PD1 inhibitors in treatment of Hodgkin's lymphoma. So yeah, so PD1. So usually PD1 inhibitors. So these are typically used in cases of relapsed refractory Hodgkin's lymphoma, as these have the Hodgkin cells have been shown to express PD1, PDL1 expression. So these are usually positive in your relapsed refractory cases, and the role of tumor associated macrophages in the outcome. So I'm not the correct person for this. I think the clinicians must be knowing, but yeah, so the role of tumor associated macrophages. So I'm not sure in the prognosis of the Hodgkin's lymphoma. Then EVV association in classic Hodgkin's lymphomas. Yeah. So for regarding the EVV association, about it differs from the region-wise different. So in India, about EVV association is pretty high. About it is more common in cases of mixed cellularity Hodgkin's lymphoma, where the association can be seen in about 70% of the cases. In cases of nodular sclerosis subtype, it can be seen in around 30 to 40% of the cases. So it differs from region to region. In the West, the EVB association is lesser than seen in the Asian or the Southeast Asian population. Role of CAR T cells. So CAR T cells. So this is a treatment clinical point of view. So this is a pathology section. Role of JAK2 inhibitors. I don't think that there is a role of JAK2 inhibitors. So these are Dr. Nadeem. These are mostly the clinical point of view. Yeah. Which clone of CD15 and J chain? So yeah, we use the Deco stain, Deco clone for the CD15 and the J chain.
Yeah, I think those are the questions as of now. If anybody on the Google Meet would like to ask a question, they can ask directly. Otherwise, we'll go ahead. I think you can go ahead, Dr. Pulkit.
Yeah. So I'll describe the cases where something went haywire, as already told from the classic IHC pattern or the morphology. So I'll describe the RS-like cells examples. So this is a case, one very recent case I signed out it yesterday. So it was a 50-year female who presented with pyrexia of unknown origin, generalized lymphadenopathy. Remember generalized lymphadenopathy, below and above the diaphragm. There was liver enlargement, spleen enlargement. So it was an extensive disease, and there was ascites as well. And the surgeon performed a core biopsy rather than taking an intact lymph node biopsy. It was a core biopsy. So this was the core biopsy that we received, and it was pretty busy biopsy, and at high power you can see a polymorphic population. So here you have some lymphoids, lymphocytes, some elongated histiocytes, spindle cells, some atypical large cells are there, and some plasma cells were there, and then another picture to show the polymorphic populations and scattered large dark cells were there. I thought it was a your mummified cells and all those things. So working diagnosis was that of a Hodgkin's lymphoma, maybe nodular sclerosis or like that, and this was one of the cells that deeply basophilic, smudgy nucleus, what is described as the mummified cell. So we went ahead with our usual panel, and the CD3 was highlighting the background. We thought it was a background reactive T cell population, and these large cells were negative for CD3, whereas there was an extensive infiltrate of CD3 population. And CD20, yeah, there was some preserved B lymphoid cells within this core and high power. Some of these large cells were showing CD20 positivity, but it was not very strong. Some discontinuous membranous positivity is there, and also in that cell, mummified cell, you have some, it is not very uniform, strong in all these cells. Somewhere it was weak, somewhere it was strong. So it was not very homogeneous. So we were convinced that it can be Hodgkin's, and yeah, we can go ahead. CD30 highlighted beautifully these very scattered large cells. The high power, you have these strong membranous positivity. Somewhere Golgi zone was also appreciated. Yeah, so we were at this time, Hodgkin's lymphoma was fine for us. But when PAX5 stain we examined, so PAX5 was not that weak or dim, and it was pretty strong as compared to the bystander B cells. So I stopped and then asked for the other immunostains. And this is the CD45, which was also not corroborating with the diagnosis of Hodgkin's lymphoma. You have these cells which are CD45 positive, whereas classic Hodgkin lymphoma usually are CD45 negative. Then we went ahead with other markers. The MUM1, MUM1 was strongly positive as expected in a Hodgkin's lymphoma. Then we were again going back to the classic Hodgkin's lymphoma diagnosis, but the OCT2 again stopped. So it was a haywire pattern of IHC. The OCT2 was strong, whereas it should be weak in your classic Hodgkin's lymphoma. Then BCL6 was also ordered, and some large cells were showing BCL6 positivity. Here some nuclear positivity. Then we were sure that these are not actually Hodgkin cells, and these are something else. And some more cells were background cells were also positive for nuclear expression of BCL6. Then we again look back at the H&E slide, and then we look at the bystander. What are these lymphoid cells? So these were not very good to us, and we thought that these can be atypical lymphoid cells, and overshadowed by these histiocytes, and some were mitotic figures were also noted. Then our thought process moved towards a diagnosis of T non-Hodgkin's lymphoma, and then we ordered other T markers like CD4. CD4 was highlighted these large cells to be positive for CD4, and it was a predominant population compared to your CD8. So CD4 was more than CD8. CD7 was also expressed in these large cells, whereas some cells were negative for CD8. So there was some sort of down regulation of CD7, not very conclusive to say. But when we ordered CD23 immunostain to highlight the follicular dendritic cell meshwork, it depicted the marked expansion of follicular dendritic cell meshwork. Usually in a reactive mode, or in cases of Hodgkin's, it should not be that much expansion, it should be very in nodular pattern of the CD23, but here you can, everywhere it is just sweeping like anything. And PD1, then we ordered markers of T follicular helper cell type PD1, which are positive in these background lymphoid cell population, and also the CXCL13, which shows typical polar positivity in cases of lymphomas derived from T follicular helper cell origin. So to summarize, we have a polymorphic infiltrate in this case. Then you have scattered large cell which are CD30 positive, 20 positive. They are negative for CD3. 45 is plus minus, PAX5 is strongly positive, OCT2 is positive, MUM1 is positive, BCL6 is positive. So you have somewhat immunoblast-like pattern and positivity rather than a Hodgkin cell. The background cell is positive for CD3 with a more ratio of CD4, CD7 is positive. T follicular helper cell markers are positive, which should not be ideally expressed on such T cells. The T follicular 3 markers which were positive were BCL6, PD1 and CXL13, and then you have expanded follicular dendritic cell meshwork as highlighted by CD23, and then you have a clinical input of extensive disease, which is not the classic history of classic Hodgkin's lymphoma. So all these fit well with the diagnosis of angioimmunoblastic T cell lymphoma, which is now a lymphoma defined by expression of T follicular helper cell phenotype. At least 2 to 3 antibodies should be positive for to call it a angioimmunoblastic T cell lymphoma. And in this case, the pitfall was the immunoblasts, which were initially interpreted as your Hodgkin-Sternberg cells. So these cases may closely resemble the actual mixed cellularity type classic Hodgkin's lymphoma. And such polymorphic infiltrate can actually overshadow these cases, the background neoplastic cells. So these have to be carefully evaluated, and always you have to keep in mind when anything goes haywire from the normal pattern of classic Hodgkin's lymphoma, you have to ask for additional markers to move to another differential diagnosis. So sometimes you can have a classic, you have a completely nice excised lymph node, and you have this lymphoid cell population which are intermediate size with a clear cytoplasm, classic cells of a AITL. Sometimes you may not appreciate them. So you have to keep in mind this diagnosis, and when these cells are showing expression of T follicular helper cell markers like PD1, CXCL13, CD10 or BCL6, it is hallmark for the diagnosis of your AITL. Sometimes such cells can also be seen in cases of PTCL, but PTCL does not show markers of T follicular helper cell origin, and then you have to take the help of your other T markers and look for any aberrant expression, the downregulation of CD7 or dual negativity of CD4 and 8 to reach at a diagnosis of PTCL and against the diagnosis of Hodgkin's lymphoma. So this is one of the categories where you can have RS-like cells. Another case 2, is a 72-year female with a mediastinal mass with regional lymphadenopathy. So this was the history which we received, and this was the Excise endobronchial lymph node, the hilar lymph node. And here you can appreciate that the capsule was markedly thickened, and beneath there is here I can say predominantly monomorphic cell population, but there was some sort of sclerosis going on there. So one can think of nodular sclerosis, Hodgkin's, or maybe some other sort of metastatic carcinoma. Carcinoma is also a possibility in this case. I thought, one of the residents thought it can be metastatic RCC as well. And then you have some small cells, you have some large lobated cells. So it was a sort of a different thing. And then we ordered the different markers, cytokeratin and opaxate and all those Mullerian markers, and all came out to be negative. The positive stains were CD30. So CD30 was positive in these cells, neoplastic cell, but it was not again very strong. It was discontinuous, not a typical Golgi zone like appearance. And CD20 was strongly positive in all these cells. CD3 was negative, and BCL6 was positive in all these cells. Then we went ahead and look at this. So this case fits well with a typically described as primary mediastinal large B cell lymphoma, where you have typical compartmentalizing fibrosis. Here you can have so thin fibrous septae often encircle these neoplastic cells, and this is typically described in case of primary mediastinal large B cell lymphoma. So you have a effaced node with the large cells, and you have this sclerosis. There's no polymorphic infiltrate, so always you have to look at the background infiltrate as well. On IHC, these are positive for B marker, CD20, CD3 is negative, but this case shows CD30 positivity, but it is usually discontinuous and not typical of classic Hodgkin's lymphoma. They show expression of germinal center markers like BCL6, and they can also show positivity for MUM1. So the diagnosis is a primary mediastinal large B cell lymphoma, which is again sometimes you can have RS-like cells in such cases. And it usually affects the mediastinal soft tissue, thymus and lymph nodes. And the characteristic interstitial collagen deposition around the cluster of lymphoma cells is the pathognomic of this diagnosis. As as already told, they express B cell markers in a strong fashion, strong uniform fashion. CD20, 79A, positive for LCA, positive for CD30, but in a weak fashion. They are positive for BCL6 and CD23. CD23 was not available at that time, so I was not able to perform this stain. And they have been shown to have characteristically positive for MAL IHC and AL IHC, so but it is not commercially available everywhere. And these are negative for CD15. So this is how we make a diagnosis of primary mediastinal large B-cell lymphoma. Case 3
Dr.
is a...
Pulkit, sorry for interrupting. There are
Yeah.
some relevant questions there on the chat box.
Yeah. I can check.
Dr. Zakaria has some queries. He also had made the diagnosis of PMBCL spot on. So
I'll
you can
just...
carry on from where you left.
Yeah. So... I think last is PMBCL. So I think he mentioned as PMBCL. So it is a correct diagnosis for the...
Prior to that, he had asked a question. I'll just put it up for you.
Yeah, we encounter cases. Okay.
Yeah, where the diagnosis somehow. Yeah, that one.
Yeah, we encounter cases where the diagnosis somehow rests on CD45 positivity. Have you seen RS cells to be CD45 positive? No. So classically, the RS cells are never CD45 positive, to be frank. But yes, interpretation is difficult. We don't rely much on CD45, and it's some may call it CD45 positive, some may call it CD45 negative, as I'll show you here. So do not rely much on the CD5 positivity. It's a difficult immunostain because you have background leukocytes. So as already shown in this, I'll just show you how the CD45 immunostain is interpreted. So yeah, CD45. So some residents, initially when I was a resident, I used to ask the asses that this is a 45 positive, this is 45 positive. Then what actual CD45 positive is when you have a sort of cell sitting here and it will be everything brown here. So it is a difficult stain. When you have two RS cells sitting together like this and you have intervening no brown deposit, then I take it as CD45 positive and then I interpret, making a final contributory diagnosis. But yes, CD45 is almost always negative in RS cells. If you will dissect out and then you will throw CD45 or do a flow, it will be negative for CD45. Yeah. So, yeah, can I move ahead?
Yes, please. The rest of them are opinions given by Dr. Pranab Bhattacharya regarding the questions which he had put forward. He has also replied them himself. So we can read those questions. Yeah. Please go ahead, sir, please. Case 3.
Yeah. Case 3. Yeah. Case 3 is a 62-year male with a left supraclavicular lymph node mass. So this was the history. Elderly male with a left supraclavicular lymph node mass. This was the only thing, and it was a multiple irregular tissue pieces that were submitted, and this is one of the field which I clicked. So at this power, you can see that there was some polymorphic population. These are some lymphocytes, and then when you closely examine here, you can see some large polylobated cells sitting here and there. Then this is the closer view. You can see that this can be Reed-Sternberg cell. This can fit well with the Reed-Sternberg cell. Here you can have this mononuclear forms and then this eosinophilic nuclei. So then we ordered our usual panel. CD3. So again, here you can say, CD3 is mostly negative. So these are the empty spaces one can encounter. The background cell is positive for CD3. This is a CD45. So this is how a positive cell should look like. The two cells are sitting together and then you have a thin membrane which is CD45 positive. This I take it as CD45 positive. Here also these are positive. So CD45 is positive, which is against the diagnosis of Hodgkin lymphoma in this case. CD20, here this is a low power view. Here you can see numerous scattered cells which are CD20 positive, and on high power these are the large cells which are showing strong homogeneous CD20 expression. So this is called as homogeneous, which is against the diagnosis of Hodgkin. So you have CD5 positivity, CD45 positivity, you have CD20 positivity, which is against the diagnosis of classic Hodgkin's lymphoma. Then you have CD30. This is not a good picture, but yes, cells was positive for CD30, but it was not very strong. Some were showing Golgi zones, some were showing membranous positivity. So it was not very typical of Hodgkin's disease. CD15 was negative. The background, this is granulocytes are positive, but CD15 is negative in these large cells. PAX5, yes, it corroborated with the classic Hodgkin lymphoma phenotypes being weak in these large lobated cells. So here also the pattern goes haywire, and so we have a scattered large cells in a polymorphic background. 45 is plus minus, CD20 is uniform strong and negative for CD3 and CD50, CD30 is positive I can take, and PAX5 is weak. So it was not fitting actually in a classic Hodgkin lymphoma pattern. So the differentials which can be considered here was whether it's a classic Hodgkin's lymphoma, it's a diffuse large B cell lymphoma, is it a T cell rich large B cell lymphoma, histiocyte rich large B cell lymphoma, or it's a gray zone lymphoma with classic Hodgkin's lymphoma and DLBCL. So points in favor of classic Hodgkin's, points against classic Hodgkin's lymphoma is strong CD20 expression, CD45 expression, and for classic Hodgkin's lymphoma is CD30 positivity and weak PAX5 positivity. So this was for this classic Hodgkin's lymphoma. For DLBCL, you have strong CD20 expression and negative for CD3. Against are that there are no large clusters of B cells. For diffuse large B cell lymphoma, you should have something diffusely positive for CD20 rather than a tidbit-like thing. And PAX5 is weak in those large cells. So PAX5 should be strongly positive in your DLBCL. It's a B cell marker. So it was not fitting with your DLBCL. For T cell rich large B cell lymphoma, you have scattered large cells which in T cell rich background, but again, against is a weak PAX5 positivity and a CD30 positive. So these are against the diagnosis of T cell rich large B cell lymphoma. For a gray zone lymphoma, the points for the gray zone between Hodgkin's and DLBCL, the points are dual positivity for CD30 and 20. So both are positive. They are strongly positive for CD20. They are weak positive for PAX5 and CD40. This was fitting with the diagnosis of gray zone lymphoma between classic Hodgkin's and DLBCL. But then we reread the book and then other DDs, then some circle do the Iberish and how it helped in this diagnosis. So most of the R cells are positive for Iberish, and so there is one more differential diagnosis which is EVV positive DLBCL. So what is this? It is typically seen in elderly immunosuppressive elderly patients who are on immunosuppressive therapy or methotrexate therapy, and it typically shows polymorphic population as those seen in your classic Hodgkin's lymphoma. So it is not a diffuse, so it is a DLBCL which is not a diffuse type. It shows neoplastic cell which are typically scattered large cells, and they often co-express CD30 and B cell markers, and they are negative for CD15. But here also the PAX5 positivity should be strong. So and these contain the transformed cells which are centrocytes, immunoblasts, plasma cells, anaplastic cells, so like that. So the only against point with DLBCL was a strong weak PAX5 positivity in this case. So finally we labeled it as a gray zone lymphoma with features intermediate between classic Hodgkin's lymphoma and EV positive diffuse large B cell lymphoma, and we asked the clinician to treat it as DLBCL. So finally, he has to take a call, which is initially they treat it as the R-CHOP and then reassess for the residual disease. So I have still to get the follow-up of this case, but yes, it was not very typical. It was a challenging diagnosis for us. So why I didn't label this case as T cell rich large B cell lymphoma? Because it was showing B cell marker positivity, but PAX5 was weak. There was no eosinophils, and EVV should be negative in T cell rich large B cell lymphoma. A positivity for EVV is for a diagnosis of EVV positive DLBCL. So this is how a T cell rich large B cell lymphoma look like. You have scattered large cells, these lobated cells in the background of reactive lymphoid cells. And these are positive for CD45, these are positive for CD20, and there should not be large clusters of these atypical lymphoid cells for making a diagnosis of T cell. There should be scattered large cells. No sheeting is permitted for making a diagnosis of T cell rich large B cell lymphoma. And this is the background CD3 positive population, the T cell rich background population. The CD30 is negative in these large cells. And this is how it looks like. Another differential diagnosis of RS-like cells is anaplastic large cell lymphoma, especially the Hodgkin-like variant of ALCL, where you can have this polymorphic background population comprised of eosinophils, lymphocytes, and you have this scattered lobated cells. And when you do IHC on a Panel 2, you include ALK as well, and these are beautifully highlighted as ALK positive with expression of T cell markers. Especially the syncytial variant of a nodular sclerosis Hodgkin's may resemble ALCL, including the presence of cells with reniform horseshoe nuclear resembling hallmark cells. So the markers which are helpful in distinguishing are the ALK protein, T cell markers, CD15, 45, PAX5, EMA, and EBER. So EBER is always negative ALCL and is positive in your, can be positive in your classic Hodgkin's lymphoma. And so PAX5 is almost always negative in ALK. So PAX5 helps in the differential diagnosis of Hodgkin's versus ALCL, and also EBV is always negative in your ALCL. So this is how this is one of a pitfall. Another site of RS cells are the ulcers, and these are the RS-like cells. So these are the ulcers confined to your oropharynx, skin, and gastrointestinal tract, and these are typically seen in immunosuppressed individuals, be it age-related or some primary immunodeficiency or iatrogenic immunosuppression or HIV. So when such patients present with isolated ulcers, not a generalized ulcer or any other thing or a lymph node thing, so I'll describe it with an example. So it was a 61-year female with a history of foreign body sensation in throat for the last 7 months, and ENT surgeon on examination noted ulceroproliferative growth over the left tonsillar region, and she was a known case of rheumatoid arthritis on methotrexate, and the ENT surgeon biopsied that ulcer region. So this was the ulcer. You have this ulcerated mucosal lining epithelium, and beneath that there's a rich lymphoid infiltrate. On a closer view, there was a polymorphic population composed of mature lymphocytes, plasma cells, and some scattered larva cells. So this cell was sitting here, lobated cells. The CD3 highlighted the background reactive T cell rich population, and CD20 highlighted these scattered larva cells were sitting in this region. And these cells were also positive for CD30. So it was large B cells which were positive for CD30 as well as for CD20. And when we did the EBV immunostain, the EBER-ish, it was strongly positive in these cells. So this is a new entity described as EBV positive mucocutaneous ulcer. It described in the current WHO classification. So they are usually present as isolated ulcers and sometimes affect the regional lymph nodes. So these usually have a good prognosis with spontaneous regression, and the typical immunophenotype of these RS-like cells are CD20 positive with co-expression of CD30 and EBV. Hodgkin's lymphoma, extranodal Hodgkin's are mostly very rare, and this diagnosis should be kept in the mind when you have some ulcerated lesions and cells showing CD30 positivity. The fifth case, the second last case, is 62-year male with generalized lymphadenopathy for 4 months, and there was history of loss of weight and loss of appetite. And on clinical examination, he had enlarged tonsils, and with firm multiple discrete lymph nodes were noted in bilateral neck, axilla, and in guinal region. So there was a generalized lymphadenopathy. There was no hepatosplenomegaly, and the hemogram was normal. This case has been contributed by Dr. Kaniappan when he was senior resident here. So this is the low power view of the excised lymph nodes. At low power, you have a nodular pattern of configuration. The architecture is phase. You have closely opposed nodules, and these nodules have shown markedly expanded mantle zones, some with residual follicles, and like that thing. So it was a subnodular pattern of lymphoma, maybe low-grade follicular lymphoma or a mantle lymphoma, or maybe marginal like thing. So this is again, so when we look at the high power within the nodules, so this is the pattern also. It was composed of small to intermediate size monomorphic population of lymphoid cells. There was no centroblast or tingible burst. It was not a reactive thing. It was a monomorphic population. And this is the high power view, and some cells were showing somewhat irregular contours, some angulations, and these, when we immunophenotype, the nodules were positive for CD20, they were negative for CD3, and they were positive for CD5. So B cell population showing CD5 positivity, think of mantle cell, and yes, it was mantle cell positive for cyclin T1 and SOX11 expression, and BCL2 and CD23 was done additionally as a part of panel. When we looked at the more morphology within the internodular regions, so this was the region, and then we looked at these cells. Some large cells were sitting within these cells, within a background population of small lymphocytes. So these were, we thought, some uh, maybe some Hodgkin-like cells, and then we thought to characterize these as well with the help of Hodgkin's panel. So these were these cells, lobated, all those polylobated, multinucleated cells, bizarre-looking cells. And these were also seen at the margins of these nodules and the internodular area. So one can see the cell sitting here and there. On IHC, these were CD45 negative, so we took this pattern as CD45 negative. These were negative for CD20. These were negative for PAX5, and these were negative for CD3. So this was corroborating with the Hodgkin lymphoma of Hodgkin pattern of IHC. They were characteristically positive for CD30, Golgi zone, and membranous positivity. BCL2 was positive in the cytoplasm, and cyclin D1 was negative in these. So it was not a pleomorphic variant of your mantle cell lymphoma. And 15 was showing some Golgi zone positivity in these cells. CD5 was negative in these cells. So what we have, and the Eberish was positive in the large scattered cells, and the fish for cyclin D1 IgH fusion shows positivity, indicating translocation 1114. The bone marrow was hypercellular and shows diffuse infiltration by atypical mature appearing lymphoid cells, which were positive for you can say CD5 positive. They were CD5 positive and CD10 negative. They were CD23 negative. They show kappa light chain restriction, and these findings corroborate with the diagnosis of mantle cell lymphoma, as these were all CD20 positive and they were also positive for your cyclin D1. So in marrow we have infiltration of Hodgkin's lymphoma, and in marrow we have infiltration of mantle cell lymphoma, and together with the presence of RS cells. So both were standing equally at their place. So finally the case was signed out as a composite mantle cell lymphoma with classic Hodgkin's lymphoma. So sometimes you always don't have RS like cell. You can encounter in rare scenario the classic RS cells along with a bystander lymphoma. So one more case from our institution was a case of CLL with Hodgkin-like Reed-Sternberg cell. Here we had a case of CLL who developed Richter's transformation with RS-like cells. So it can be seen. So these cells were characteristically showing the CD15 positivity, 30 positivity, and negativity for 45, and weak expression for PAX5. This is the last case, 60-year male, massive splenomegaly and night sweats with a mediastinal lymph node. So there was a disease in spleen, there was disease in the mediastinum. FNA, ultrasound guided FNA from your this mediastinal lymph node was signed out as Hodgkin's lymphoma, and then so these were the smears. So it showed a polymorphic population of lymphoid cells, and there was scattered large cells which are characteristically typical of Hodgkin cell with a prominent nucleolus, and you have these binucleate classic Reed-Sternberg cells. So it was signed out as Hodgkin's lymphoma, and the staging marrow was performed, and but in marrow there was lymphocytosis. There were 33% lymphocytes and lymphoid cells, and these were not mature appearing lymphoid cells. These were atypical, having some irregular nuclear contours and everything. So here was a discordance. In TBNA you have Hodgkin's lymphoma, and in marrow you have some sort of clue for non-Hodgkin's lymphoma. The flow was performed on this case, and CD19 gated cell population showed kappa restriction, and they were negative for CD23. They were showing heterogeneous positivity for CD5, and they were positive for B cell markers. They were negative for CD10 and other T cell, and they were also negative for hairy cell markers 123. So it was signed out as CD5 negative, 10 negative, B NHL compatible with the diagnosis of marginal zone lymphoma, and this is the defined biopsy showing nodular aggregates of lymphoid cell, mature appearing lymphoid cells. You have some megakaryocytes and these lymphoid cells, paratrabecular infiltrate as well as nodular infiltrate. Some areas were very hypocellular as well, and some areas were showing together presence of these mature appearing lymphoid cell, and in between sitting are those mononuclear variants of Hodgkin cells. And this is more of pictures to show these variants of Hodgkin cells sitting in the same triphyine biopsy. So these were sitting together, and these are CD20 positive cells, your nodular nodules of your mature lymphocytes, and the large cells were negative for CD20. CD3 is positive in your background T lymphocytes, whereas large cells are negative for CD3. So still going with the diagonal Hodgkin's, large cells were positive for CD30, and this is a closer view to show that those two cells are positive for membranous positivity for CD30 and cytoplasmic as well. CD15 was negative in these cells, so it didn't help. CD45 is negative in these large cells. ALK is negative in these large cells, so it was finally signed out as splenic marginal zone lymphoma with classic Hodgkin's lymphoma, a composite lymphoma, and it was advised to see the splenic histology, and this was the PET scan where you can see the enlarged spleen, uptake in the enlarged spleen, and some neck nodes were also showing uptake with SUV of 5. So finally the splenectomy was done, and here you can see very enlarged spleen weighing almost 2 kg, and on cut surface it was not typical of your red beefy surface. Here it is showing nodular whitish nodules on the cut surface, and on this is a microscopic section showing closely opposed nodules and expansion of the white pulp and compromise of the red pulp, and there is marked prominence of the marginal zone. So this pattern is typically described in marginal zone lymphomas, treating marginal zone lymphomas, and this is a closer view to highlight some the intermediate sized lymphoid cells, though here there was no presence of those atypical large lobated cells in the spleen. And these are positive for CD20 and negative for CD3. The B cells were showing expression of CD43, BCL2 is positive, the mantle cell lymphoma markers are negative, and CD30 was negative. So it was splenic marginal lymphoma in the spleen, Hodgkin lymphoma in the mediastinal node, and in marrow they got fused and both were showing infiltration in the marrow. So it was a composite lymphoma. So when two or more histological types of lymphoma involve the same site, we then term it as a composite lymphoma, and it can be clonally related or it cannot be clonally related. So possibly in this case they were clonally unrelated. One lymphoma arises in the spleen, another in the lymph node, but they got fused in the marrow. So when they are clonally related, so they describe as initially a clone develops which acquire a second hit, and one proceed towards the development of one lymphoma and other develop towards a progression to another lymphoma. So in such scenarios, you can have actual RS cells together with a background, together with a synchronous other NHL. Then there are, so I'm just maybe a few more slides are left. So RS-like cells can be seen in benign lymph nodes and in certain non-lymphoid neoplasms. So most dreadful diagnosis, tough diagnosis is infectious mononucleosis, where you can have presence of these scattered Hodgkin-like cells in a background of lymphoid, mature appearing lymphoid cells, and these can be CD20 positive and can be confused with your any DLBCL or T-cell rich large B-cell lymphoma. But CD30 is not very strong in these cases, and then you have to dig out the history, look at the smear to look for any downy cells or transformed lymphocytes, and follow-up of the patient is advised, and a clinical correlation including test for EBV specific antibody can clinches the diagnosis. So it usually, the history is a typical involvement of Walder's ring and usually seen in young individuals. So in young individuals, you have to, when you are making a diagnosis of EBV positive DLBCL or like thing, you have to take it with a pinch of salt and think of a diagnosis of infectious mononucleosis. Other rare diagnoses which can be confused with RS-like cells are undifferentiated nasopharyngeal carcinoma, which can mimic syncytial variant of nodular sclerosis, classic Hodgkin's lymphoma when it metastasizes to a lymph node, but here the cells are show keratin markers and negativity for 15 and 30. The other differential rare diagnoses are the metastatic melanomas in a lymph node or an extragonadal germ cell tumor like the embryonal carcinoma. So to summarize, two RS cells can be seen in your classic Hodgkin's lymphoma or a composite lymphoma where Hodgkin's lymphoma is a part, and should be accompanied by characteristic background in inflammatory cells and fibrosis. They show strong and homogeneous CD30 expression, and they are negative or variably positive for B cell markers. The RS-like cells, they can be seen in high-grade lymphomas or really low-grade or B or T cell NHLs. They doesn't show any characteristic background. CD30 expression is variable, sometimes very strong, somewhere almost discontinuous, and the B cell markers here are more strong and homogeneously expressed like CD20, 79, and PAX5. So you can add your B cell marker like 79 to more consolidate your diagnosis of RS-like cells. So to summarize, RS-like cells can be seen in your anaplastic large cell lymphoma. The T-cell lymphomas are the AITL and PTCL. In the DLBCL and variants, they can be seen in your primary mediastinal large B-cell lymphoma. They can be seen in EBV positive DLBCL, T-cell rich large B-cell lymphoma, EBV positive mucocutaneous ulcer, and gray zone lymphomas. They can be encountered as bystander immunoblastic proliferation in cases of follicular lymphoma, mantle cell lymphoma, marginal zone lymphoma, or CLL as well. And the most challenging diagnosis is a reactive lymphadenitis because of Epstein-Barr virus, the infectious mononucleosis. So you can have this list in your mind where you can encounter the RS-like cells. So the take-home messages regarding these scattered large cells in a polymorphic monomorphic background is: get clues from available clinical history. Do not hesitate to call the clinician or the nuclear medicine guy for the SUV or the clinical presentation or the pattern of disease. Pathologists can talk to patient as well for the history. Get information from other disciplines like cytology, hematology, lab medicine, biochemistry. It is always helpful. And appreciate the morphology of background cell population. Is it polymorphic? Is it monomorphic? The size of the lymphoid cell population and any sclerosis. Classic Hodgkin's lymphoma usually requires uniform strong CD30 expression. CD45 if positive may help, if negative it cannot negate a diagnosis of Hodgkin lymphoma. They are negative for 45 and CD3, and they can be positive for CD20 and other B cell markers, but these should not be uniform strong positive. And be alert if this pattern goes wrong. Think of RS-like cells and proceed with more markers. So with that, I would like to acknowledge all the members of the lymphoma management group, and especially my mentors, Dr. Ashim Das and Dr. Amanjit Bal, for their constant preachings. And I would like to thank other departments who contributed for the lymphoma management group patients. And thank you. With this, I am ready to take questions and comments.
Right. Thank you so much. Wonderful presentation. There are some comments as well as some questions on the chat box. You can go there as in the meantime.
So they tell, thanks, CD45 positive, it is a headbanger at times. Yes, it is a headbanger, but it is, I feel, sometimes very helpful if you have a nice CD45 stain. So it is usually not a CD45. We take everything into account for calling it a case as this. How much do you rely on the absence of eosinophils and plasma cells in making a diagnosis of T cell rich large B cell lymphoma versus other, especially NLPHL? Yes, definitely. So for T cell rich large B cell, I don't rely. So if there are few eosinophils, so I don't rely actually on the amount of these eosinophils. Some cases can show florid eosinophilia. Some cases may show just scattered eosinophils. Just I take a maybe just 5% clue from these bystander cells. The majority I rely on the immunohistochemistry, because ultimately they are going to answer as well as the clinical scenario. And a lot of confusion. So core biopsies. So you can MCL with RS-like cells, excellent. So maybe you can, sir, ask. I think if you still have doubts for a question.
Yeah, we will just wait for a minute, because in the meantime I will put my comments. In the meantime, because there is a 30-second lag between your presentation and the YouTube.
Ask a question?
Yes,
Radhika here, and excellent talk, Pulkit.
Thank you.
And excellent cases also. So one is, residents, they're always excited about eosinophils and plasma cells. So sometimes, you do get many cases, in fact, of Hodgkin's, where you may not find eosinophils or plasma cells. So
Definitely.
just to put it in perspective, what proportion of them would have everything that you want, like the polymorphous typical background, and which are the ones where it doesn't have. At least in my experience, good number of cases may not show, and it may be so minimal that you may miss it. That is
Yes.
question number one. You can note down.
Yes, ma'am.
Question number two is, at least on cytology, sometimes we've had cases where, it gets reported as even granulomatous inflammation. And then, of course, a repeat FNAC has picked up the Hodgkin's. I do not know whether this happens in histopathology, and what is your take on that?
Yes.
Number three is, I have seen a few cases only, particularly in the nodular sclerosing variant, where you have numerous neutrophils. So I do not know, it used to get called as suppurative Hodgkin's and sometimes neutrophil-rich Hodgkin lymphoma, some sort of an aberrant kind of response, tissue response due to something related to some cytokines or something like that. And in fact, I remember two cases which in fact had formed pus. We actually aspirated pus, but we saw these atypical cells, and of course, later on, everything fell into nodular sclerosing Hodgkin's. So just wanted to add that. And again, if you have experience on such cases, you could also take that up.
Yes.
Over.
So, yeah. Thank you. Thank you for the wonderful questions. So, yeah. Firstly, regarding the eosinophils, so maybe whatever cases during my tenure I have seen. So, mostly sometimes the florid eosinophilia I do encounter rarely. Only in cases of typical mixed cellularity I do encounter, whereas in other Hodgkin lymphoma cases, I do have to hunt for the eosinophils. I have to look for the eosinophils, whether they are present or not. And yeah, so eosinophils may or may not be present in cases of Hodgkin's lymphoma. Even in cases of I have seen bone marrow aspirates as well. So even in also those cases where there was a Hodgkin's lymphoma infiltration, the eosinophilia was not that prominent in such cases, whereas plasma cells were seen in the marrows as well. So eosinophilia per se, classic ones are encountered maybe in the 5 to 10% of the cases. Rest cases, one has to hunt for the eosinophils. So and the reason behind this is maybe differential expression of your CD40 ligand and your eotaxin expression by your this RS cell. So usually eosinophils are attracted to those cells, and then they harbor they make the milieu of this, and maybe it can be related to the differential expression of the eotaxins or other inflammatory cytokines for the eosinophil recruitment. Secondly, yes, granulomas. So granulomas, we have burnt our hands 2-3 times, and Dr. Das sir also knows regarding those cases. So when even now I have one more case, the clinician is saying no, it is lymphoma, and we are signing out as a sarcoidosis. And once it was a child, 12-year male child, who we got a block review from outside, and the lymph node was showing florid granulomatous response. And I got a preaching from Dr. Das that one should always look for RS cells in those cases. And when we performed the CD30 and other markers, it turned out to be Hodgkin's lymphoma. So granulomatous response is seen in such cases. And thirdly, regarding the suppurative abscesses in cases of Hodgkin's lymphoma. So these have been described in cases of your nodular sclerosis Hodgkin's lymphoma, as I've already highlighted one of these slides, where you can have abscesses because of neutrophil rich thing, and they have been described in cases of your lymphocyte depleted variety as well. So yeah, abscess have also been described in cases of Hodgkin's lymphoma. It is all related to the inflammatory milieu of the Hodgkin cell, because Hodgkin cells express so many aberrant molecules where they recruit the inflammatory cells, lymphocytes, plasma cells, eosinophils, neutrophils, and it is which one overtake the other dictates the type of inflammatory milieu that cell is harboring. NLPHL may not be having that much expression of cytokines, so that's why it is having just lymphocyte-rich background. Whereas the nodular sclerosis and your mixed cellularity have lots of eosinophils or neutrophils in the background.
Thank you, Pulkit.
Thank you, sir.
for his excellent talk. I just wanted to highlight the CD30 is almost like a double-edged sword. It helps you to reach a diagnosis of certain condition like Hodgkin's and anaplastic large cell lymphoma. But one has to be careful. CD30 can be seen even in benign condition, lymphoid condition. One of them is essentially a Kikuchi's lymphadenitis, but one particularly in the proliferative phase. But this immunoblast, which is CD30 positive, are essentially T immunoblast in Kikuchi's lymphadenitis.
Yes.
So one has to be careful about this. Second thing is in a nodular lymphocytic predominant Hodgkin lymphoma, you can see outside the B nodules, you can see some CD30 positive cells.
Definitely.
But one should not jump into conclusion that this is classical Hodgkin lymphoma, not nodular lymphocytic Hodgkin lymphoma. And there are many other situations which you have already mentioned, like T cell lymphoma can have immunoblastic proliferation, that can have a CD30 positivity. So these are the small points that I just wanted to highlight.
Thank you, sir, for adding to the list. Yeah, so immunoblast, it is a very pitfall in the diagnosis of Hodgkin's lymphoma. You can see immunoblast in any sort of lymphomas, I would say, be it low grade or high grade. Yeah, and there is some question here. In some scenario, the maximum SUV PET sometimes help. How much does it really helps in classic Hodgkin's versus NLPHL versus T cell rich versus PMBCL? Yeah, so and the SUV uptake helps in scenarios where you have a differential between high grade lymphoma and a low grade lymphoma, maybe DLBCL. So it usually helps in such scenarios like your NLPHL will have a least SUV uptake compared to your classic Hodgkin's lymphoma, but your PMBCL SUV uptake will be more. So we do, when we have a discorrelation between a clinical and a pathological diagnosis, we put those cases in the lymphoma round and discuss, or maybe we discuss directly with the nuclear medicine guy. So sometimes even when you have a like follicular lymphoma cases, some locations can have a low SUV uptake indicative of grade 1 follicular lymphoma, and some where it is very high SUV uptake. So we have seen a case where one lymph node biopsy was showing a grade 1 follicular lymphoma, another one was a diffuse large B cell lymphoma, and we picked up with the help of nuclear medicine only. So SUV is very helpful in cases of differential diagnosis when you have a doubt between low grade and high grade or a transformation sort of thing.
There is another question by Dr. Rajesh Agarwal also on the chat box.
Yeah. So is the clinical preparation have any difference in these patients which have mantle cell with Hodgkin's lymphoma? So no, there was not much clinical, so both will have your B symptoms and all those hepatosplenomegaly. There was no such difference because the clinician never suspect it is a Hodgkin's. He always suspect it is a non-Hodgkin's. So sometimes you can have because it was a synchronous, it was not a metachronous, it was synchronous thing. So I don't feel there was any difference between a pure mantle cell lymphoma and a mantle with a Hodgkin's lymphoma. It was an advanced stage lymphoma which has involved marrow. There was cytopenias. It was systemic disease. So it was just like any garden variety of high grade non-Hodgkin's lymphoma.
Right. Any other comment? And there is one more question on the YouTube. I will just put that across.
Yeah, sure.
Check it's on the way actually, because. Yeah, I can see it now. Just please 1 second. Yeah. Yeah, you can read it now. I put it there, right?
Yeah. Any particular T cell marker which you rely more in such situations such as CD7? So I rely, most reliable marker is CD7 loss. So it is the most reliable marker which we use because CD5 is usually retained in TNHs. So dual negativity for CD4 and 8 or dual positive, equal proportion of CD4 and 8. And the topmost marker islet is CD7. So CD7 loss is commonly seen when you have a PTCL or other NHL or TNHLs. CD5 is usually retained. It parallels with that of a CD3 expression.
Right. Anybody has any more comments or questions before I start giving my opinion on this?
Yeah, just one more small thing. Just wanted to add that On cytology, of course, that case was beautifully highlighted. The Hodgkin cells and the RS cells have a very, very prominent nucleoli. So particularly in cytology, it is easier to distinguish between an immunoblast and a Hodgkin cell. Easier. Not saying it's always the case. Mistakes are always made, but it is easier. So I think Pulkit made in this last statement, you see, talking to each other is very, very important, particularly in difficult cases. And, so in many of these cases, the marrow would have been done for staging, and FNAC would have been there. And then you get particularly in core biopsies, the diagnosis can be very challenging as compared to excisional whole lymph node biopsies. So, it's very important, and that is a very, very important message, I think, that the histopathologist should reach out to both his or her cytopathology and hematopathology colleagues, and also to the clinician and nuclear medicine, and before you actually give out a diagnosis. So don't give out a diagnosis and then it gets discussed in the rounds and then you revise it. Talk to each other and then you'll be able to arrive at a correct diagnosis more often than you think. Thank you.
Right, absolutely perfect. Anybody else? Okay, so let me now add on some things, like there are all experts here, right? Me sitting here in Calcutta, I would like to talk on behalf of most of these people who are working in the private sector. So is it time for us now to talk about these lesions and sign them out as lymphoproliferative disorder with RS-like cells, rather than sticking our neck out? Because most of us here, majority of us here in the rest of the country who are working in different areas may not have access to all the immunomarkers which you have, and with so many differential diagnoses, gray zone lymphoma, oral ulcers, EBV mucocutaneous type, composite lymphomas, and so many scary ones coming across, it would be now prudent enough to ask for us, rather than signing out as Hodgkin disease, and rather than signing them out as Hodgkin disease, we should write lymphoproliferative disorder with RS-like cells and then ask them to go ahead with the rest of it.
Yeah, definitely. So there are scenarios when you don't have any access to immunostains, and then you are seeing these typical. If you have a classic morphology, as I described in my initial slides, those nodules and excised lymph nodes and all those things, you can give consistent with the classic Hodgkin's lymphoma. I advise further workup by immunohistochemistry. But if you are receiving a core biopsy specimen, and if you don't have further full panel of immunostains, so I would say just sign out as a suggestive of Hodgkin lymph. You can give a suggestive Hodgkin lymphoma, lymphophere, whatever you are saying, and you can refer it to the higher center where a tissue can be saved, because making a core biopsy from the abdomen, it's a precious tissue. One should not waste the tissue, and can send it to other higher center wherever the immunostains are available, so that from that limited tissue one can have the sections and can do these immunostains for a correct diagnosis. So the approach is good. So we do some, for the first case which I showed, AITL, it was initially signed out based on histology only, and the block was referred to us, and then we tried to make the diagnosis. But sometimes we have the outside pathologists, they do everything without making a conclusive diagnosis, and we have just a 0.2 centimeter tissue available to us, and then the patient is in a fix and the other biopsy is done, and then you have delay in the diagnosis. So this approach is a little bit not very good, but the approach you told is pretty good and fits well.
I am talking more more particularly in FNACs.
No, can I just add to the debate or discussion?
Yes, ma'am, please.
Yeah, so yes, it is challenging. You see, some years ago, maybe 20 years ago, you could do a diagnosis of Hodgkin's lymphoma on morphology. Everybody was happy. The patient, the oncologist would treat the patient, and almost a good number of them would, be cured and other things solved. But we have come now. We have come to an era where you have to do IHCs. Okay, even if everything is classical on morphology, they will say please do the IHC. So when it comes to FNAC particularly, you have to have a cell block. So at this point of time, without cell block, IHC on the cell block, just giving out a morphological diagnosis, you can only say suggestive of Hodgkin's lymphoma, like Pulkit said. You can go up to that level, and then you say kindly do a core biopsy or whatever for confirmation if you're not doing a cell block. But if you're doing a cell block, then you must have a really good cell block with tissue cores in it, mini cores in it, for you to be able to interpret the IHC correctly. So having said that, when we just did an audit, we found that we had a very good accuracy for a diagnosis of Hodgkin's lymphoma, even on the basis of morphology alone. So it was well over 90%. But yes, in your private setup, you have to play it safe. You can say it is suggestive of Hodgkin's lymphoma, and of course defer the final diagnosis to IHC, either on a core biopsy, or if you have a good cell block, at least up to level 1. In my experience, what Pulkit showed in the first slide, the level 1. If everything is classical, your level 1 IHCs are supporting the diagnosis of Hodgkin's lymphoma, you can go and give a proper diagnosis of Hodgkin's lymphoma. Beyond that, well, leave it to the lymphoma specialists, I would say. Even a general surgical pathologist may have a problem if the level 1 doesn't work. And Pulkit has beautifully shown us cases where everything can go haywire. So that is not amenable to a general surgical pathologist. Please, even those of you in practice, you get core biopsies, even if you get excisional lymph node biopsies, if you're not a lymphoma pathologist, it's not a good idea to go and sign them out. Refer it to a higher center or another person who has expertise in that, and will be able to crack the case. Thank you.
Yeah, I agree 100%. Exactly, that's what we are doing here. We don't touch lymph nodes. Yes, you can really burn your fingers. I mean,
yes.
even the best morphology showing you a reactive, picture can really come out to something very dangerous. So the general teaching at the peripheral area and the private sector to everybody down the junior line is be very careful. Ignorance is bliss. Knowledge brings all that fear and caution. So it's always better to be cautious than to be regretful. That is exactly what we all do, and that is what we teach. And I'm so thankful that the experts are here to add to this, because the whole idea of these lectures are that they go back on record, and then people across the globe, they'll listen to it and they will learn. It's just unfortunate that the second lecture is now going to follow this lecture. Actually, Dr. Kavita Jain's lecture was supposed to be 3-4 days before this, but unfortunately something went wrong in her place, so we could not have that. That was a basic pathology of Hodgkin's. Anyway, we will be having that on the 12th. But the whole idea, this is such a good discussion, because this is how everybody will learn what to do and what not to do. Caution is very important. Overzealous activity can really burn your fingers. I'm so thankful that if all the experts are here to give their opinion. Dr. Pulkit, would you like to say something on that before I close the session?
Yeah, I would like to add one more thing. So even sometimes the lymphoma experts have difference of opinion. So when I have a different opinion, I go to the Dr. Das, or maybe Aman ma'am, or maybe I can go to Radhika ma'am also. So yeah, we do discuss and we reach at the final diagnosis. We keep on learning as well. So it is a continuous art of learning which defines, because these criteria are changing, the concepts are evolving, so one has to keep on learning and do read what is available from in your area of expertise, what are the recent publications are going on there, so as to refine your understanding. So that's the thing. Thank you.
So before I close, I would like to read out all the comments of your lecture. So we'll start. Dr. Ashim Das and Dr. Radhika says excellent talk and cases. Then Dr. Amanjit Bal, excellent presentation. Dr. Kirti Gupta, great talk. Dr. Pulkit. Dr. Rajesh Agarwal, excellent presentation. Dr. Rahila Manish, thank you Dr. Pulkit for such nice talk and cases. Dr. Zakaria Chowdhury, excellent case sir, learnt a lot. And Dr. Ritambra, you talk directly from heart and soul. I think I agree with that 100%. Thank you, Dr. Pulkit, for coming here and teaching us so much, sharing your knowledge. and all the experts, my teachers, Dr. Das, Dr. Radhika, who are here, who have been there always to teach us, and we've been learning. Thank you all for coming, Dr. Kirti, Dr. Amanjit, Dr. Rajesh Agarwal, and so many people, about 30-35 people on the YouTube who have been here listening and putting their comments. Dr. Zakaria, Dr. Pranab, thank you so much. God bless you, Dr. Pulkit. Excellent presentation. Good night. Take care, everybody.
Thank you,
Bye-bye.
sir. Bye-bye. Good night.
Thank you. Bye. Bye.